And these are those drugs that alter renal sodium transport. And they are the ones that you call diuretics. Diuretics. Then you got a second group, which are those agents that modify neurohumoral volume regulators. And if you remember the first slide of the previous lecture, we talked about the volume regulators. Mentioned 4 systems. Mentioned the renin-angiotensin system. Mentioned the natriuretic peptides. Mentioned ADH, antidiuretic hormone. And we also mentioned the sympathetic nervous system. Those are the ones that modify volume regulators. But we will not talk about the sympathetic system now, because from time to time you'll be hearing, and you'll be hearing, of course, about drugs that affect the sympathetic system. So let's go on to the diuretics for today. The first group of diuretics we'll talk about are the osmotic diuretics. And why osmotic is because they operate by the principle of osmosis. So if you remember the definition of osmosis from your high school biology, the movement of substance from higher to lower concentration. So that's the way it works. And a very good example of an osmotic diuretic is mannitol. Mannitol. And what happens with mannitol is that this is a small molecule. It is filtered at the glomerulus, but not reabsorbed. Let me explain, because I don't want to go too fast today. I just want to remind you that when you have the glomerulus this way, you have the afferent arteriole supplying blood into the glomerulus, and you have the efferent one taking blood away from the glomerulus. This is efferent, this is afferent. Okay? And in here, you have the glomerular membrane. So that when blood reaches here, ions are filtered and they go first into the proximal tube. Then the proximal tube feeds into what we call the loop of Henle. And this one feeds into the, so this is the loop of Henle. This should fill into the distal convoluted tubule, and this will go into the collecting duct. And from this, the urine that is formed is passed out into, the urine is passed out. Okay? Now, so when ions, as ions, which is mainly sodium, potassium chloride, are filtered through here, they have to be reabsorbed. Because if they are not reabsorbed, then you're going to lose so much of electrolyte, and you don't do that. So the function of the kidney, first at the glomerulus, is to filter all the sodium, all the chloride, and all the potassium, bicarbonate, and all that. But if all of that as is filtered just goes out the system, then there's trouble. So along the line, there's reabsorption of those ions back into the blood, so that what comes out eventually out of here is only 1% of what was filtered here. Okay. Now, when we talk about mannitol acting as an osmotic diuretic, you give the mannitol, it gets filtered at the glomerulus. But unlike the ions, it's not reabsorbed. So if it is not reabsorbed, what then happens is that there will be a reduction in the reabsorption of water, because the mannitol is osmotic. It would attract water to itself. So as mannitol sits in here, there's a lot of water around it. A lot of water around it. So because it's not reabsorbed, the water is not reabsorbed. Okay? So the mannitol now passes with a lot of the water, and that's how you get osmotic diuresis. Is that clear? Is that clear? I want to make sure that is clear. Mannitol works as an osmotic diuretic, attracts water to itself. Since the water is not reabsorbed, it can only go out in the urine, and that's what you call diuresis. And of course, where sodium, water, and all that goes, then you find the effect. So the effects are greatest at the proximal tubule, because this is where you get the greatest water reabsorption, at the proximal tubule. So if the water does not get reabsorbed, that means it does not get back into the body, then it gets out. So the water that is lost is greater than the amount of sodium that is lost. And that's why you end up with a hypernatremia, and you have diuresis. You also have natriuresis. Okay? You have natriuresis, you have diuresis, and you have hypernatremia. What are the uses of osmotic diuretics? You use it in managing an increase in intracranial pressure. See, when you find patients that have aneurysm, one of the problems is water starts collecting in their brain. You need to get rid of that excess water. So this is when you use mannitol. It will reduce the intracranial pressure, because a lot of water is being lost, and that increase in intracranial pressure can come from trauma, can come from hemorrhage, and that is the same thing as aneurysm. So that does it with osmotic diuretic. Let's go to carbonic anhydrase inhibitors. What you will know for now is that there's this popular reaction. When water combines with carbon dioxide, it gets converted to hydrogen ions and bicarbonate ions. Okay? This is a reversible reaction, because as it goes in this direction, it also goes in this direction, so that there is a constant maintenance of the levels of hydrogen ions and bicarbonate. What makes it possible is the enzyme called carbonic anhydrase. Carbonic anhydrase is responsible both for the dissociation of this into this, and for the recombination of this bicarbonate and hydrogen ions back to hydrogen and back to water and carbon dioxide. So there are two types of carbonic anhydrase. There is one inside the lumen. Okay, so this is this is the lumen of the nephron. There's one right inside the lumen, and there's another one right inside the cell itself, inside the cell of the tubule. So if you draw a tubule like this, and this is the cell itself, here is the lumen, here is the tubule, and this will be the peritubular capillary, where you get reabsorption. Peritubular capillary. So let's see what happens in a, let me show you the next slide, so at least I can explain that better here. Now, so look at the hydrogen ion and the bicarbonate combining to form carbonic acid, H2CO3. The H2CO3 breaks down to carbon dioxide and water. And this happens under the influence of carbonic anhydrase. This happens to be carbonic anhydrase type 4. Now the carbon dioxide and the water that is formed from the carbonic acid gets transported inside the cell. See, like I said, this is the lumen, this is the cell of the table, this is the, like in the membrane part of it, okay? And this is the peritubular side of it. So the carbon dioxide and the water gets converted back to carbonic acid, and then it forms the bicarbonate and the hydrogen ions. The hydrogen ions that is formed is secreted. This transport mechanism, NHE3, I'll mention it shortly also, is called sodium hydrogen exchanger. NHE means sodium hydrogen exchanger. And the meaning of exchanger is you give me this, I exchange this for you. You give me this, you exchange for this. So if hydrogen ion is supplied to this transport mechanism, then sodium comes in. Hydrogen goes up, sodium comes in. Hydrogen gets here, is secreted, sodium comes in. Now, what makes this possible inside the cell is carbonic anhydrase type 2. So type 4 is in the lumen, type 2 is inside the cell. And the effect of it is to do exactly what we're talking about. So there are certain agents that cannot block these enzymes. So let's see what happens if carbonic anhydrase is blocked here. When it is blocked here, this is not converted to this, right? So where does this carbonic acid go, or the bicarbonate, where does it go?
It stays in the lumen?
Huh?
Does it stay in the lumen?
It stays in the urine. And that's what alkalinizes the urine. When you have bicarbonate in the urine, you are causing alkalinization of the urine. Okay, that's one step. The other step is this. When you block inside here, the carbonic anhydrase 2, and the hydrogen ion is not formed because it does not go into this at all. There are two things that happen. The carbon dioxide and the water just stay here because they don't go inside the cell. Where does the water go? In the urine too. So because we are talking of the lumen, so it still stays in the lumen. So it becomes two things. There's water that's going in the urine. There's bicarbonate that is alkalinizing the urine. And the last step that you need to know also is this, because this is not occurring. Hydrogen ions is not being supplied to this transport mechanism. So if hydrogen ions is not being supplied, where does sodium stay?
Outside.
It stays outside. So that's why when you give carbonic anhydrase inhibitors, these are the things that will happen. There will be sodium excretion because there's no hydrogen ion going there. There will be bicarbonate that is going in the urine, alkalinizing the urine, and there is water that is going there. So that is how this is a diuretic. Am I clear?
Yes.
Clear?
Clear. Yes.
Very good. Okay. I know I rushed the lecture, the one I recorded for you. That's why I'm taking my time now. And I have more time to deal with the other things. So let's now go to this stuff. So what acetazolamide, a typical carbonic anhydrase inhibitor, does is to inhibit the proximal tubule cytoplasmic carbonic anhydrase type 2, and the one in the lumen, which is type 4. And this occurs in the proximal tubule. So what's the result of that? There's an increased delivery of sodium bicarbonate. You now see where the sodium is coming, where the bicarbonate is coming. So, and since this is occurring in the proximal tubule, which is here, then there's a greater delivery of sodium and bicarbonate other than the latter segments of the network. So what are the effects produced by carbonic anhydrase inhibitors? They can cause mild to moderate metabolic acidosis. Because when they inhibit hydrogen secretion in the proximal tubule or inhibit acid secretion in the collecting duct, they will alkalinize the urine. That's where I'm getting at. And one advantage of the alkalinization of urine is that it operates on the principle of neutralization. You get more acidic drugs that you want to excrete from the body, you alkalinize the urine. If you get an alkaline drug that you want to excrete in the body, you make the urine acidic. That's the way it works. So because of the alkalinized urine, then you get an increased excretion of organic ions. And this also includes aspirin, which aspirin is acetyl salicylic acid. So that's how you get an increased excretion that way. Then the other thing is this: when you inhibit carbonic anhydrase, it affects the secretion of aqueous humor. And the aqueous humor, vitreous humor, both are products from the eye. So by inhibiting the secretion of aqueous humor from the eye, you are treating glaucoma there and there, because excess secretion of aqueous humor can cause glaucoma. And then carbonic anhydrase is also involved in the secretion of chloride ions and bicarbonate into the cerebrospinal fluid. And because of the ability of these agents to inhibit carbonic anhydrase, you will soon see how this comes into usefulness, clinical use here. So what are the clinical uses of carbonic anhydrase inhibitors? Now, one is in the treatment of glaucoma, and that's coming from here. The other one is in the treatment of acute mountain sickness, which is characterized by, anytime you see XB in my note, that's characterized by nausea, headache, dizziness, insomnia, pulmonary embolism, confusion, and all that. It can also be used in the treatment of epilepsy, and that's where topiramate comes in. And when you deal with CNS pharmacology with Dr. O here, we'll talk more about epilepsy. And then it can restore acid-base balance, especially in heart failure patients when they have metabolic alkalosis. Yeah, because when there's metabolic alkalosis, and you know that these agents cause metabolic acidosis, you can relate to why they are useful in that situation. They can also be used in the management of gout because they reduce the reabsorption of bicarbonate and therefore they alkalinize the urine. Then they can increase the solubility of uric acid. Don't forget what I talked about alkalinizing urine to increase the excretion of acidic drug and vice versa. So that is all about carbonic anhydrase inhibitors. I'm taking time to explain these two groups of diuretics because they are a little more complicated than the rest. The rest are pretty much straightforward. No, I don't think I gave you that. So, tell me whether this statement is true or false. Mannitol inhibits hydrogen ion secretion in the proximal tubule and causes metabolic acidosis.
False. False.
False here?
Yeah.
I want more answers. Mannitol inhibits hydrogen ion secretion in the proximal tubule. Okay, let me say the second one. Acetazolamide is indicated for the treatment of acute mountain sickness.
Okay, true. Yeah.
That is true. So the one you have an issue with is mannitol. What class of agent is mannitol as a diuretic? Osmotic. Does osmosis have anything to do with hydrogen secretion?
No, you said water absorption.
Does with water absorption. Which one inhibits hydrogen secretion? I took my time to.
Carbonic 2.
Huh?
I thought it was carbonic 2.
That's carbonic anhydrase inhibitor. This is the one that inhibits hydrogen ion secretion. I just told, and that's the basis for the alkalinization of the urine. Okay. All right. So that first one is false. Number 2 is true. Now let's talk general about the other diuretics. These are the agents that reduce sodium reabsorption, and so they reduce the driving force for osmosis, and therefore they can lead to sodium excretion because there's a reduction in water reabsorption. They target sodium reabsorption along every segment of the nephron. And forget the third bullet. These drugs are the mainstay of antihypertensive treatment for a long time, but the mechanism of action is still not fully known. But what we know about their effect is that they reduce intravascular volume. Because when you excrete a lot of water, intravascular volume will go down. And how does that happen? They increase the renal excretion of sodium and water. There are 3 types. There are the thiazides, that the loop diuretics, and then the potassium-sparing diuretics. And talking about sodium transport in specific nephron segments, and I've always asked a question on this one, so I don't care what to do. I will ask you a question on this slide. And you need to know that in the proximal tubule is when you have the NHE3. We just talked about the NHE3 in the previous slide with carbonic anhydrase inhibitor. That's sodium hydrogen exchanger. It's here. Sodium potassium chloride transporter is found in the loop of Henle. And this is where the loop diuretics work because they target this transporter. In the distal tubule, you find the sodium chloride co-transporter. Thiazide diuretics act on this side. And in the last segment, you have in the collecting duct, you have what you call the epithelial sodium channel. And this is where the third class of agents actually act. That is the potassium-sparing diuretics. Okay. So when I ask you which, I would like to know usually that you know which transporter is present in which segment. If I tease you and say this is present here or the other way, you know that I'm just kidding you, so don't kiss me back. Because you will miss the question and then don't ask me. So for the thiazide diuretics, what they do is they competitively antagonize sodium chloride co-transporter in the distal convoluted tubule. That's what in the last slide. And what are the effects you get? The diuresis they produce is modest. And therefore they do a modest reduction in intravascular volume. But they have a direct effect as a vasodilator too. So because of that, because of these 2 effects, they are able to reduce blood pressure. And when I treat antihypertensive next semester, we will do this exact slide again. It will be a repetition. So then please note also that these diuretics will increase calcium reabsorption. So when they increase calcium reabsorption, they are therefore useful in treating those patients in which they are having a lot of calcium wastage. If a patient is losing too much calcium, then it makes sense for you to give an agent that will cause a reabsorption of the calcium into the system. And that's why in patients that have osteoporosis, they have low calcium in their bones. We can't afford for them to lose all that. So thiazide diuretics increase calcium reabsorption, and they are useful in treating them. Same is true when you have hypercalciuria, patients that are losing too much of calcium. Then you want to give this agent. These diuretics are the most commonly prescribed diuretics, and they are the first they're the first line of treatment. They have a high oral bioavailability and a long duration of action. Any of these statements that I put in red, it's important for you to take note. Okay, high oral bioavailability and long duration of action. And I've given examples of 3 of them: chlorothiazide, 6 out to 12, clothalidone, 48 to 72, and hydrochlorothiazide is 16 to 24. And they are very useful, especially in patients that has volume-based hypertension, because the hypertension is volume-based. We want to get rid of as much volume as possible. And this is usually so in those that have renal disease, or those who are plaque. Then, what are the side effects of thiazide diuretics? The most frequent problem you have with them is hypokalemia. So by losing a lot of potassium, you end up with a hypokalemia. How do you know a patient has hypokalemia? Person will complain of muscle weakness, will complain of cramps, will complain of paralytic ileus. What are the other side effects? Because of the increased calcium reabsorption, you end up with hypercalcemia. Then you can have hyperuricemia, you can have hyperglycemia, and hyperlipidemia. That's why patients that are on thiazide diuretics are always candidates to be monitored for diabetes and cholesterolemia, because they cause hyperlipidemia and hyperglycemia. Then, forget about this. We go to the loop diuretics. What are the examples of agents in this class? Furosemide, torsemide, and I mentioned torsemide and furosemide in the recording I told you.
Torsemide is better.
Which one is better?
Torsemide.
Torsemide is better, very good. Then we have bumetanide and etacrinic acid. These ones act in the thick ascending limb of the loop of Henle, and they target this transporter. So their primary effect, of course, is to reduce sodium reabsorption, and they cause an increase in potassium secretion. They also cause hypokalemia, just like the thiazide diuretics, and they can cause metabolic alkalosis. And next week, when I treat acid-base balance disorders, we'll mention this drug again with respect to metabolic alkalosis. Now, unlike the thiazide diuretics, these ones will cause a reduced reabsorption of divalent cations like calcium ions. The other one increase. This one will reduce the reabsorption. And it's usual for me to ask you the difference between loop diuretics and thiazide diuretics. This is one of them. So this one has hypocalcemia, the other one has hypercalcemia. What are the effects? Is very well tolerated, but there's dose-related ototoxicity. There's hypokalemia. And what is the difference between one loop diuretic and the other? It is in terms of potency. For example, bumetanide is more potent than the others. It's the most potent of all these groups. And what do you use them for? You can figure that out from the properties that I've just mentioned. Okay. Now, the loop diuretics have the highest efficacy of all the diuretics. So it's much more potent than thiazide diuretics. And I put in red here, unlike thiazides, I told you, one, they increase urinary calcium excretion, that's why they end up with hypocalcemia. And they're effective in patients with poor renal function. For thiazides, they are not as effective in patients with poor renal function. Unlike thiazides also, these ones have short duration of action, whereas the thiazides have long duration of action. Then, what is it that is new here? Side effects, hypokalemia, ototoxicity, which is deafness, and that is most common with ethacrynic acid. What are the other effects? Metabolic alkalosis, acute hypovolemia because of the strong diuresis that is produced. The last of that group there are the potassium-sparing diuretics. And these ones are less efficacious. And they are used primarily in combination with others. You don't use potassium-sparing diuretics to treat hypertension because they are not strong enough. Just like you don't use carbonic anhydrase inhibitors to treat hypertension. They are diuretics, but you don't use them. The potassium-sparing diuretics are only used, especially when you are correcting the hypokalemia that we've mentioned with the thiazide and the loop diuretics. So what do? They increase potassium reabsorption. So if you give a thiazide, for example, and you are worried about losing too much potassium, you add a potassium-sparing diuretic. There are two mechanisms of action for this, but both mechanisms target the epithelial sodium channel in the collecting duct. Don't forget, I said I will want to know specific transport mechanism and where on the nephron is located. So the first mechanism is to antagonize aldosterone receptor. And the two drugs that we know that are aldosterone receptor antagonists are spironolactone and eplerenone. Then the next one are those ones that competitively inhibit the activity of this channel itself directly. And what are the examples? Amiloride and triamterene. How does aldosterone come in? The ENEC, the epithelial sodium channel, is controlled by aldosterone. And when the aldosterone binds to the mineralocorticoid receptor, it increases the activity of this transporter. By increasing the activity of this transporter, there will be more sodium that is reabsorbed, and therefore that leads to intravascular volume. And that's why you get sodium retention. When you have agents that stimulate aldosterone, you get sodium retention because of an increase in intravascular volume. But given these agents, you can reverse that effect because you are antagonizing the aldosterone. And because of the strong effect on potassium reabsorption, they said you have to avoid giving ACE inhibitors. ACE inhibitors are known to reduce aldosterone activity. Don't forget, when you stimulate renin-angiotensin system, you also stimulate aldosterone, correct? That's why we call it renin-angiotensin-aldosterone system. So when you're blocking angiotensin, you're automatically blocking aldosterone too. And since aldosterone causes increased potassium reabsorption, what it does is it reduces potassium excretion. So the combination of ACE inhibitor and potassium-sparing diuretic will now produce such a great reduction in will now cause too much of potassium in the system. So that now becomes a problem of hyperkalemia. You want to correct hypokalemia, you're ending up with hyperkalemia because you are using two agents. If you are giving ACE inhibitor and you are giving potassium supplements at the same time, that will end you up with hyperkalemia. One of the things you always tell your patients that are on the thiazide or the loop diuretics is to take potassium supplement to correct for the hypokalemia. That's why some of them, a number of them, you encourage them to take banana. One banana a day, there's a lot of potassium in banana. It's a way of correcting for the hypokalemia. But when doing that, be wary if an ACE inhibitor is in the system. So, okay, what are the adverse effects of potassium-sparing diuretics? Of course, hyperkalemia is the major danger. And then you can have androgenic or estrogenic effects. And I will leave the androgenic and estrogenic effects in terms of the details. I will leave that since you are coming to me next semester. I don't have to give you everything now. But I'm using the same slide when you come next semester. That will be the first lecture when you come. You're coming for 541, right?
Yes.
Poda 2. So you're going to meet me just shortly in January. So you've seen the same slide again, so I'm repeating that for you. So let me hold my fire here. And I know you have too much in your head now.
Thank you.
Okay. So let me know if you are following me. Thiazides are the most prescribed of the diuretics. Is that likely to be correct? Yes or no?
Correct.
That is correct. They are the most prescribed. Triamterene. Do you know which class of agent is triamterene?
Potassium sparing.
Very good. This is it. Triamterene is what?
Potassium sparing.
Is potassium sparing. So, potassium sparing diuretic is as effective as hydrochlorothiazide in the management of moderate hypertension.
False. No, false.
Very good. Furosemide inhibits sodium chloride co-transporter in the group of N.
False.
False.
No. Oh, yes. It's in the
It's the potassium.
DCT.
Okay. The NKCC is the one that's in the loop of Henley, and that's the one that furosemide had. So, pay attention to my questions because it would look like, oh yeah, sodium chloride, yeah. Then,
It does.
So there's nothing like, yeah, I got it. Okay, you didn't get it. Okay, now, let's now go to this other group. These are the drugs that alter natriuretic peptides. Don't forget, I'll say it again. We mentioned 4 volume regulators. Natriuretic peptides, we mentioned AMP, BNP, CMP. We talked about the 3 receptors, NP, RA, BC, and the guanylyl cyclase and all that. And then drugs that alter, yes ma'am?
Did you skip a couple of slides?
That's for me. It's not for you.
Oh.
When you become professor, I'll give that to you.
Okay.
But that's going to be some years from now. Okay, so let's talk about the natriuretic peptide, DNP. Whatever I've given to you in the lecture note I sent out, I know that that's the one I'm going through. Any extra I bring is my choice. So the B-type natriuretic peptide, the agent that acts on this receptor is called nesiritide. And what's nesiritide? It's nothing but a recombinant human brain B-type natriuretic peptide. And we know the natriuretic peptide have 2 effects, if you remember.
Yes.
Natriuresis and vasodilation. Natriuresis and vasodilation. So it's used for short-term management of decompensated heart failure. And in heart failure, according to my recording, you have 3 approaches. You decrease preload, you decrease afterload, and you increase contractility. Thank you very much. Okay, good. So in this case, since we have a natriuretic peptide, you are going to decrease the preload, right? Because you are reducing intramuscular volume. That's why you use it in heart failure. And because you also, it also causes vasodilation. That would be another reason for which you will use it. This is ineffective when you give it orally. And you know why? Because it's a peptide. Peptides get degraded when you give it orally. That's why you don't give it orally. But what are the effects? Because of the vasodilation, it will reduce vascular resistance. It will increase stroke volume, and it will increase sodium and water excretion. What are the adverse effects of nesiritide? If you reduce the blood pressure too much, it can cause hypotension. And with the hypotension, and there's not enough blood being supplied to the kidneys, you can end up in a renal dysfunction. Renal dysfunction. That's it about natriuretic peptide. The next one is the vasopressin or antidiuretic hormone. And here we talk about the antagonist and the agonist. So just to remind you again, there are two receptors for vasopressin, right? There's the V1 that's located where?
The smooth muscle.
Very good, in vascular smooth muscle. And there's the V2 that's located in the collecting duct.
Yes.
And one is responsible for contraction, the other one is responsible for
Water reabsorption.
water reabsorption, antidiuresis. I want to set that. Is that clear to everyone? So once we know what V1 is doing and what V2 is doing, then that makes it easier for us to now say, demeclocycline is the first of the agent. We don't know the mechanism of action of this, but it is used in the syndrome of inappropriate ADH secretion. When antidiuretic hormone secretion is not appropriate, then what you end up with is, instead of having antidiuresis, the vasopressin is antidiuresis, which means it keeps the water in the body. So when there's inappropriate secretion of this, there is too much of the ADH being secreted, and there's too much of water being retained. So when you give demeclocycline, it is to help correct for the excess ADH secretion, so that you don't end up with water retention. Now, codivaptan. This is a non-selective vasopressin antagonist. Okay, because it's non-selective, that means it acts on both V1 and V2. So it can cause both vasorelaxation and it can also cause vasoconstriction. So what are the disadvantages of this? It can only be administered IV, and it has some V1 receptor antagonist activity. You would like to use it for the V2 receptor antagonistic activity, not the V1, okay? Now you have tolvaptan. Tolvaptan is your typical V2 receptor antagonist. And this one, I didn't need to tell you that it will be useful for this too. Because when you have too much of secretions of ADH, and you are worried about water retention, then you need a V2 receptor antagonist. Is that clear?
Clear.
Okay, it should be clear. Let me repeat. V2 receptor is related to water retention. It's located in the collecting duct. Okay? V1 receptor is the one that's in the vascular smooth muscle. The one that you need in cases of too much water in the system, like edema and all that, is a V2 receptor antagonist, because you do not want water retention. Water retention is coming from excessive antidiuretic hormone activity. So you can give this, but the disadvantage of this is that it also has V1 receptor antagonist activity, which you don't want. This one is straightforward V2 receptor antagonist. And good thing is also that it can be given orally. Then you use it for what? SIADH. You use it for heart failure. You use it for cirrhosis. All of these situations are edematous situations. If you remember what I said about cirrhosis, there's water retention, there's ascites. In heart failure, we went over it, how edema, water collects in the heart and it collects in the system, and excessive secretion of antidiuretic hormone. Then, of course, you have desmopressin, which is a vasopressin agonist. In this case, this will now be useful in diabetes insipidus. And you know what diabetes insipidus is. Telepressin, forget about telepressin, because it's just investigational at this stage. And that leads me to the last one, which are the inhibitors of the renin-angiotensin-aldosterone system. And when you want to inhibit the renin-aldosterone system, you can attack it in different ways. One, you can start with the renin itself. Renin is the enzyme that converts the angiotensinogen to angiotensin 1, and then angiotensin 1 converted to angiotensin 2, you hit it with the ACE inhibitors. And when the angiotensin 2 has been formed and is acting on its receptors, you hit it with the receptor blockers. And then you know that once angiotensin 2 is produced, aldosterone is also produced, so you want to antagonize the aldosterone. So these are the 4 steps and the 4 targets of inhibiting the renin-angiotensin system. You start from the get-go and you work it all down the line. I just mentioned to you spironolactone as a potassium-sparing diuretic, right? Because it acts as an aldosterone receptor antagonist. So what's a good example of a renin inhibitor is aliskiren. It will reduce angiotensin 2 production, but will increase bradykinin levels. And let me explain this one for you. Before I go too far, this is the one that explains it. When you inhibit angiotensin 2 formation and you inhibit all of this, or in the process of the synthesis of angiotensin 2, you got angiotensin converting enzyme that works here, right? We know that. But what happens is this: the same enzyme that metabolizes angiotensin, that converts angiotensin 1 to 2, is the same enzyme that breaks down bradykinin into inactive fragments. Bradykinin is one of those autocoids or mediators that mediate pain, that mediate hypersensitivity reaction, and does a couple of things. So as you are converting angiotensin 1 to 2, which is good, you are also breaking down bradykinin into inactive fragments. Once you now block the ACE inhibitor, which is good, angiotensin 2 is not formed. What happens is that bradykinin is not being metabolized. And this bradykinin causes cough. It causes angioedema. So when you find some patients that are on ACE inhibitors complain of cough, it's because there's accumulation of bradykinin. Got it? So ACE inhibitors doing good here on one hand, but at the same time, you end up with something you really don't want at this other end. So let me go back to that slide and so the adverse effect. So when you reduce angiotensin 2 production, you also increase bradykinin levels. Is that clear to all of you why you get that? And that's why you now get the cough, you get the angioedema because of the bradykinin. Now, the renin inhibitors are known to precipitate first dose hypotension because the blood pressure can reduce so much that when you give the first dose, it causes hypotension that you really don't want. So it's one of the adverse effects. And it can also cause ARF. And I think your group has a lab today on ARF. Okay. So I talked about ACE inhibitor-induced ARF in my recording, correct? Remember? You remember that?
Acute renal
ACE inhibitor-induced renal failure. Okay, you may want to this. So this can also cause ARF. And these agents can cause hyperkalemia because anytime you inhibit angiotensin 2, you are affecting aldosterone 2. And that's how the hyperkalemia comes about. When do you use the renin inhibitors? In hypertension, in acute myocardial infarction, and in chronic kidney disease. So I will continue from here next class. Okay. All right. Any question? Okay. If there's no question,
Any pointers for the exam on Monday?
any what?
Pointers for the exam on Monday?
Any pointers for the exam on Monday? All I can tell you is that none of the stuff today will come. That's the greatest I can give you. How can I give you a pointer on one lecture? Come on now, get serious. I just give you a lecture. You're looking for pointers in one lecture? Wait until I finish 5 lectures, then we can talk about pointers. Otherwise, I can only do this. I'm pointing at each of you, and then go read that. So, all I just tell you is that the number of my questions, I hate to tell students pointers sometimes because then you take it too far.
No, we won't take it too far.
No, you take it too far, then you end up with, oh no, I didn't know that. All I can tell you is that I have fewer questions on the ones I recorded because I wanted to give you a break. The ones that you're looking at me and I'm looking at you, I loaded some questions more on that side. But now this is where the problem comes. You now get there, you're expecting 2 questions from my recording.
So you have 10 questions, correct?
On Monday,
Is it 10 and 10, or how would it be?
I think, no, 10. Yeah, 10. I have 10 questions.
Oh, okay.
On Monday, yes, I have 10 questions.
Because I think it's a 20-question exam.
It's a 20-question exam.
I think. I'm not sure. Please,
Hold on. I think I'm confusing it with the quiz now.
Yeah.
I'm confusing my information with you with quiz. No. Let me take that back. So don't. I didn't say anything. I know for your quiz, I think. You know what? I'll send to you. So don't let me miss it. Because there's another exam that I'm giving pointers, so I don't want to.
Okay.
Yeah. I will send to your classroom and then let you know. I'll correct myself whether they're waiting. But that's the pointer I have for you. Okay.
So, but Sunday is the quiz. Would it be, at what time will it be on Sunday?
What's your usual time? Is it 7 to 9 or something?
Usually 5 or 6
5 or 6. Okay, 5 or 6
to 9.
To 9?
Because we have assignments that day, so he expands it. So for some who want to take it early, some who want to take it later.
I see. So 5 to 9?
Mm-hmm.
You are unbelievable. You're impossible. Okay. I think.
It's everyone with their own schedule. Some people, they have to work. Some people, they want to take it early and get it over with. It's just to accommodate everyone.
To accommodate everybody. I know it's usually difficult to accommodate everybody.
Yeah, so you try your best.
You try my best. Okay. You have a good class rep, huh? Okay. All right, we'll see. This is 5 to 9. I'll discuss with the doctor here and then. I'll try and keep it in line with what you are used to. So that don't let me rock the boat. I don't want to be the reason for you not doing well.
No.
Oh, sir, how many quizzes for your section?
Quizzes for my section on
Renal.
The renal as a whole.
As a whole.
for the Sunday quiz.
No, I'm saying how many
as a
total,
whole,
as a whole.
in the whole
Are you
section.
giving us 2, 3, 4 quiz? How many for your section?
Oh, I think it's going to be 2 at this rate. Yeah. Are the quizzes for raking undeserving points or what?
No, why would you say that?
No, that's right. When you said that you now want more quizzes than
More
exams.
quizzes so we can,
Prep
you know,
for the
prep for the
final.
exam,
It helps
final.
Okay, oh yeah, and now that I'm here, yes. Okay. I know you have another one next week. I'm trying to finish my lectures next week so that it gives you
More time to study?
To study.
Hey, God,
Hey,
thank you.
God bless
So
you. Yes.
that's where I'm cutting between the number of quizzes I can give you. So at the rate we are going, I'm trying to finish next week.
Okay.
So that from Thanksgiving, you don't have to see me. I don't have to see you until next semester.
God bless
Amen
you, sir.
to that one too.
I'm serious.
But you'll see me next semester.
Yes.
That's when we'll be in trouble, huh?
You'll be in trouble. Oh my goodness.